Good afternoon. My name is Andrew Bluestein, and I am here with my colleagues Lara Jean Ancona and Stacy Klein to talk to you about an act which is less than a month old, and that's the Right to Try Act. I want to thank everyone who is going to spend the next hour with us. We have a very impressive audience. You're mostly from the provider community, you're hospital administrators, healthcare lawyers, physicians, researchers. So we're going to gear our presentations toward the provider community. After the session is done, we will send you the slides, and we're also going to post it on YouTube if you want to share it with some colleagues. We're going to, if time permits, take some questions. If you put out questions and we don't have a chance to get to them, we will send you emails. And if you have questions afterwards, you can contact any of the speakers whose names and contact information are in the back. So this is a difficult law to do a webinar on. Part of it is that there was no comment period, and it is in effect. So it's been in effect since May 30th. So there are times where we're going to tell you we're not sure, and these things will have to be developed. But the law is extremely confidential. There are a lot of supporters and detractors, and our goal today is to put the audience in the position of being able to form your own opinions, but more importantly, it's to help you figure out how you begin to implement this. So if you're following along on your hymnals now, we're up to slide, hang on, we are up to the second slide, which is the agenda. We're going to explore the background of the law, which is what I will do, and then Stacy Klein is going to take over and begin to talk about the analysis of the Right to Try Act. For the lawyers on the phone, there is a very complex site. It is difficult to find. If you get on your Google browser and put in Right to Try Act, Senate law, you want the Senate version, you will see it there. There are other versions that are floating around that we don't think are accurate, but the law is in effect. And so we're getting a lot of phone calls from even some of you on this webinar saying, do I have to comply? Can't I wait? And the answer is no. And the difficult question is, how do you comply? So after that, Lara Jean Ancona is going to take us through more of the analysis, and then we're going to get into a review of perspectives. Because depending on who you are, a manufacturer, a physician, a hospital, an insurer, you're going to look at this differently. And I think that even if you're not one of the listed, for example, if I'm talking about hospitals, but you're a physician, there's an interrelation among all the perspectives that you're going to need to understand. Then we're going to talk about some next steps. And again, time permitting, we're going to take some questions. Okay, so there are estimates of over 1 million patients a year who die from a terminal, Americans who die from a terminal illness. And if you're one of those patients, unfortunately having a terminal illness, before the Right to Try Act comes into effect, you have some options. You could obviously be on a clinical trial. There are thousands of clinical trials going on every day, and you could be a patient in one of those. They are limited. They're not open enrollment to anyone who wants, and you have to meet certain criteria. So there is a small percentage of patients that actually get on clinical trials, but that is the most plowed ground that we have. Now, there are patients for various reasons who can't be in a clinical trial. Let's say they're of the wrong age, or they have another illness or something else that prevents them from meeting the criteria of a clinical trial. They can be in expanded access, which is another very well-plowed road to getting non-approved drugs. Some people refer to expanded access as compassionate use because you're giving it to the patient through compassion, not because they meet a clinical trial protocol. Unfortunately, that is where the controversy starts. Although the FDA has approved 99% of the requests for compassionate use, only about 1,000 people make it through that process each year. We're going to try on this call to be agnostic about where we are on the law, but the people who are very strong in the right to try camp think that the process is too overwhelming, it's too complicated, and it leads to a delay. The time to get it approved is about a couple of weeks. That's our understanding. Again, there's not hard data on that. But the process has been criticized, and that is what led to the right to try. Now, if you're following along, we're on slide 4. The states really take the action first. About 40 states, and these legislations by and large grew up over the last 2 years. They really exploded. They have a version of the right to try. Obviously, the remainder of the states do not have right to try, and that includes New York, New Jersey, and Connecticut. And many of the people on this call are from those 3 states. They do not have this legislation. The problem with with these state laws is that they're inconsistent. The scope is different. They conflict with each other. They also don't deal with cross-border. So if you're in cross-state, if you're in state A and you go to a hospital in state B and the manufacturer sends it to you in state A, which law applies? But it is an avenue that exists. In Texas, for example, 78 patients reported that they received an experimental cancer treatment that was not approved of by the FDA. But the patchwork of state laws is problematic. So along comes the federal right to try, which created or tries to create a national standard, and it's an additional pathway. So you have clinical trials, you have compassionate use, that still stays as an avenue, and now you have a third avenue, which is this right to try avenue, okay? And we thought we'd spend just a couple of moments on the controversy. One, it's interesting, and 2, I think it informs where the legislation is going to end up going. So people like Representative Frank Pallone likes the current system. He thinks having the FDA involved is a good thing. It protects patients from snake oil and things like that. As an interesting aside, I think it's interesting. One of the first things I ever did in healthcare was a patient who showed up in a hospital with a drug that the family wanted to give. No one had ever heard of the drug. We called the FDA. It turns out all it was ground up shark bones. And the FDA was actually looking for where the patients got it from. That might have been the 1%. Remember, 99% get through. But the thought is that it's important to have the FDA in that role. Similarly, and we put a hyperlink there to Allison Bateman's, who is an assistant professor at NYU, her statement also in support of the current system, but suggesting that it needs to be improved. So why do we have this third way? Why don't we just improve what we have? Now, the other camp is led by Senator Ron Johnson and others, and you will see that they think that the FDA is a problem in this regard, and that the FDA should be suppressed, and what should grow out of that is the people's liberty. If you want to read something interesting, there's another hyperlink there, which is the FDA commissioner was giving an interview and said that, well, now they support the right to try, and they're going to come up with some processes to describe and guide that process. And the letter that we put there by Senator Johnson was to the FDA commissioner, somewhat aggressively, you might say rudely, attacking him and saying the FDA has no role here. Step back. This is not what you should be doing. And so the right to try has these, by the way, the legislation, if you look at it, is rather short. It does have some philosophical statements that there is this sense of liberty, which is why it's called a right to try, that is the right of an American to try and get medications that they think will save their life, hope will save their life, and the FDA should not limit that. There's also an attempt to say we're not adding new legislation, we're actually just giving this right and enshrining it in law. So that's the current lay of the land. That's the controversy. And now I'm going to turn it over to Stacy, who is going to take you through beginnings of the nuts and bolts of the statute.
Hi, thank you, Andrew. Good afternoon. So turning now to slide 7, in order to be eligible for treatment under the Right to Try Act, the patient must be an eligible patient, which requires that the patient be diagnosed with a life-threatening disease or condition. Under federal guidelines, the patient must have a disease or condition where the likelihood of death is high, or have a disease or condition with potentially fatal outcomes. Although the introduction to the Act states that the Act is for use by patients diagnosed with a terminal illness, the Act does not actually require the patient to have a terminal illness, just a potentially terminal illness. Although the word imminent is used in most state Right to Try Act legislation, the word imminent is not used in the federal guidelines and Act, meaning patients with terminal illnesses where death is not imminent may be eligible patients for the Act. Turning now to slide 8, regarding the requirement that a physician certify that a patient is an eligible patient. In order to be an eligible patient, a physician must certify that the patient has exhausted approved treatment options and that the patient is unable to participate in a clinical trial involving the experimental drug. The certifying physician must be in good standing with the physician's licensing organization or board and must not be compensated directly by the manufacturer for providing such a certification. However, there's no requirement that the certifying physician be the treating physician. With respect to exhaustion of approved treatment options, we've had multiple conversations with many physicians who have serious concerns with the certification requirement because it seems to imply that all approved treatment options have been exhausted. Regarding the second element of the physician certification, the Act leaves open who will be checking and making the determination regarding whether the patient is unable to participate in a clinical trial involving the drug. Will it be the sponsor, or will the physician be required to check the clinical protocol to determine that the patient is ineligible? So now turning to slide 9, the patient must provide written informed consent regarding the eligible investigational drug to the treating physician in order to be considered an eligible patient. With compassionate use, in many instances, it is the manufacturer who provides the informed consent form, which is often prepared based on the clinical trial for which the patient is ineligible. Here, which party the informed consent form comes from, the manufacturer, the physician, or others, and the content of such forms are issues ripe for guidance and further development. Turning to slide 10, about the eligible investigational drug. the Act permits a patient who satisfies the criteria to be an eligible patient to then request that a manufacturer provide them with access to an eligible investigational drug, which a manufacturer may or may not provide, subject to the manufacturer's discretion. To be an eligible investigational drug, the phase 1 clinical trial for the drug must be completed, meaning the drug's safety regarding the maximum tolerable dose has been tested. The drug may not be approved or licensed by the FDA, and the drug need not have been shown to be effective for the condition sought to be treated, but either an application must have been filed for approval or licensure by the FDA, or the drug must currently be under investigation in a clinical trial that is intended to form the primary basis of a claim of effectiveness in support of approval or licensure by the FDA, and it is the subject of an active investigational new drug application. The drug must also be under ongoing active development or production by the manufacturer or placed on clinical hold under the FDA's rules. Turning now to slide 11 regarding labeling requirements. Labeling must comply with the investigational new drug labeling requirements and restrictions on commercialization and promotion of the investigational drugs. However, the experimental drugs provided to eligible patients would be exempt from certain labeling requirements, including regarding directions, adequate warnings, misbranding, licensure, protections of human subjects, including the expiration dates of those drugs, IRB oversight, and would be exempt from having FDA approval for the drug and clinical testing rules. The onus for the labeling is on the sponsor, manufacturer, distributor, prescriber, dispenser, or an individual who introduces or delivers for introduction into interstate commerce the drug, or a provider of the investigational drug. This means that potentially physicians and hospitals may bear liability for inaccurate labeling. Turning now to slide 12. In accordance with the investigational new drug labeling requirements, the drug must be labeled caution, new drug limited by federal or the United States law to investigational use. There are other labeling exceptions that may apply, but those are not likely to apply here. The label may not bear any false or misleading statements. The label may not represent that the drug is safe or effective for the purpose for which it is being investigated. And promotion of the drug as safe or effective and commercial distribution of the drug is prohibited. The sponsor also may not unduly prolong investigation of a drug once enough data to support the marketing application is available, despite it being considered an investigational new drug under the Act. My colleague, Lara Jean Ancona, will now take you through some additional requirements of the law. Lara Jean.
Hi, everyone. Lara Jean. Let's talk about where we are now. Andrew gave you some general perspective and some information about the law and how it got created. Stacy just ran through some of the requirements that are under the law so that you can actually be eligible for this law. So, you know, you have to be an eligible patient, which means you have to meet the requirements of having the right disease and be in the right position, right? You have to have an eligible drug, so you have to go through those requirements and make sure that there's a drug that actually works with your disease and that it is an eligible drug. Then you have to have a physician who's willing to certify that that you are in the right position and fill out the form. Then someone has to figure out how to give informed consent, so the person has to sign. And obviously, this is the same thing as you usually use in a clinical trial, but we have to figure out who's creating that. And then we have the labeling requirements, which is now on everyone, not just on the manufacturer, so that becomes a greater concern. All right, so those are the rules we've talked about so far, so I'm going to talk about some of the other rules that are in this law. The first thing I'm going to talk about is clinical outcomes. So one of the concerns, obviously, here is the manufacturers aren't required to do this because you would never require them to do it, but how do you sort of entice them maybe to do it? Well, one of the things that you want to consider is whether or not the outcome is going to be used against the manufacturer, because why would I give you a drug under this Right to Try Act if then you're very sick and you're going to die anyway, and then that outcome is used against me? So the Congress tried to deal with this by including these clinical outcomes exceptions. So basically it says the clinical outcome of a use of this drug for the Right to Try Act cannot be used to delay your approval or to adversely affect the review and approval of your drug. But of course, Congress can never stop, like with something as simple as that. So then they went on to say, unless, and they give the reasons why it could be used against you. One of them is pretty simple. Oh, you know what I forgot to do? Move the slide along. I apologize for that. Okay, one of them is pretty simple, which is the sponsor requests that they use the outcome. So I guess if it's a good outcome, the sponsor can come along and say, you know what, I want you to use that outcome. The other one is if the FDA determines that they want to use the outcome. And reasons why the FDA can determine that are, it's pretty specific. So the FDA has to determine the outcome is critical to determining the safety of the drug. They have to provide a written notice to the sponsor. That is critical, and a public health justification for such determination. That has to become part of the administrative record, and the determination has to be made by somebody pretty high up in the food chain. The secretary, the director of the agency center that is charged with pre-marketing review, or someone senior to that director. So obviously this was an attempt to make the manufacturers feel more comfortable, but they weren't going to just leave it out there that you could never use the adverse event because maybe there's a public health reason. All right, so let's move on to the next slide. This would be slide 14. Okay, so here's, although the Congress gave them, the manufacturers some enticement because they said they wouldn't use clinical outcomes against them, they then went on to say that the costs also couldn't be great. So this law talks, this portion of the law talks about how much of the cost of the actual making of the drug the manufacturer can charge to the patient. And it's pretty limited. It's only direct costs, okay? So what is that? That is the cost incurred by the sponsor that can be specifically and exclusively attributed to providing the drug for investigational use. It's not overall, it's just the cost for the investigational use. It's the cost per unit to actually create that drug. So raw materials, labor, and other things, but only for the cost of actually making the drug we're talking about, not overall. And you can't allocate it, it's just this particular cost. And the direct cost to ship and handle the drug to wherever it's going, okay? So that's a very limited amount of cost that can be incurred. And then the manufacturer has to support the calculation by providing supporting documents to show exactly how they did the calculation and how it's consistent with the law. And then they have to find a certified public accountant who reviews and approves that calculation. So it's pretty limited of what they can do for the costs, right? And under the Expanded Access Program, the costs are greater that you can pass through. Be that as it may, this is the right to try. We're empowering people, so they try to keep the costs down. If you go to the next slide, it actually goes on, the law goes on to say all the costs that you can't include. So any indirect costs. So it's cost to produce the drug, all the costs that get included in creating a drug. The research, all the background stuff, all the first tries, all those kinds of things. Those are not things that you can include, right? Research and development, administrative labor, other costs that would be incurred in a clinical trial that wouldn't be incurred in this very specific use, the cost that expanded access allows, cost of monitoring, protocols, the cost of creating the informed consent, all these kinds of things, labeling, these are not things that are directly attributable to giving this drug, so it's unclear. Like, it doesn't specifically say you can't include that, but if you did include it, you'd have to come up with the reasoning, and you'd have to get, put that in your little calculation and show how it's attributable to the law and have a certified public accountant sign off on it. So this is an area where the manufacturers may think twice about giving a drug because they're limiting their ability to charge people for it. Okay, moving on to the next one, we get to the annual summary report. So this is another requirement under the law. manufacturers or sponsors have to submit an annual summary of any drug used under this act. So it has to be the number of doses supplied, the number of patients treated, the use for which the drug was made available, and any known serious adverse events. Now that sounds like it undercuts the, I can't use the clinical outcomes against me because now I'm listing known serious adverse events. I guess it would be the same things that you would know otherwise because you were doing a clinical trial, but the law's a little unclear as to what exactly that means. This whole section didn't really have a lot of detail, so that's the annual summary. The Act requires the issuance of regulations regarding submission deadline, and it permits amendments to the regulations to require submission in conjunction with annual reports for the investigational new drug application. So in the future, these reports could be part of the annual new drug, the new drug application that they do, the IND, which actually would undercut maybe the requirement that there's no clinical outcomes being used against you, because now you have an actual report about adverse events and how many times you used it, that kind of thing attached. So it's a little unclear, but that's what this annual summary report talks about. And then if we move on, there's a posting of the annual summary. So the law requires the posting of the annual summary on the internet website of the FDA. I assume the FDA is going to create a new section of their website that talks about right to try, and they're going to have these things on there. So it's going to have the number of drugs for which clinical outcomes associated with the use of the drug listed there. It's going to have the basis of the Secretary determinations, the use it's going to talk about what the clinical outcomes that were actually used, either the basis for the Secretary's determination, that the sponsor required it, or it's not used. So there is going to be a listing of how many people got the drug and they didn't use the outcome. So that's, I don't know what that means or what it doesn't mean, but it's there. And there's also discretion for additional reporting required. It's unclear what else would be required, but that these two sections, the summary reports, are a little unclear as to what exactly is going to be happening. Of course, the FDA supposedly is working on some guidance. Hopefully when they do that guidance, this would be something that would be required. Since most of the people on this call aren't really manufacturers, I don't know how much anybody cares about this. So moving on, limitation of liability. So the law specifically has a limitation of liability for anybody who has an act or admission in connection with giving this drug, basically. So if you give an eligible investigation of drug to an eligible patient under this act, you would not be responsible for acts or admissions to do that if you are a sponsor or manufacturer, if you're a prescriber, dispenser, or other individual entity. Now, after going back and forth and around in a circle about this, it seems like this would include almost everybody. Obviously, the manufacturers are listed, prescribers, dispensers, and other individual entities would seem to cover physicians, hospitals, all the people that would be involved. So there's no liability, of course, unless, there's always an unless, you have a reckless or willful misconduct, gross negligence, or an intentional tort under any applicable state law. So of course that raises the question as, how would the state laws interact with the federal law, and how, what are we talking about here? So the exception is pretty limited. So I think, and after talking to some litigators, it seems to us that unless you do something grossly negligent and it falls under some tort that could be brought against you under a state law, this law pretty much trumps. So if you follow the law and you do what you're supposedly supposed to do under this law, you would probably have a limitation of liability. There's also no private right of action under this law. Okay. So that's basically the law in a nutshell. It's not that long, as Andrew said, and that's pretty much what we're talking about. So moving on to perspectives, we're going to talk about some perspectives of the different, from different points of view, from the manufacturers, from the physicians, from the hospitals, from the patients, from the FDA, from the insurers, and from the states. I'm going to start us off with discussion of the manufacturer ones, and then you'll get to hear Andrew's melodious voice again. Okay. Manufacturers. So their perspective. There is no requirement to provide the drugs. Now, I know there were some articles recently written about the right to try drugs where, where most manufacturers just said they weren't going to get involved. There was one exception, which was Bayer, which kind of said we welcome it and we would be open to it. But there were a bunch of other ones that just said, why would we do this? Of course, that opinion might change over time, but that's kind of where the initial reaction, and they aren't required to do this. There's obviously a concern about adverse reactions and how that would be used against them, how it would be used to derail their FDA review or approval. Obviously, Congress tried to address that, but there are some loopholes because it's unclear what the reports would say and how much detail they would give about adverse events and how many bad outcomes you would have. There are concerns about impacts on clinical trials. Do they want patients who otherwise could be in their clinical trials or aren't really eligible for their clinical trials running around trying to get other drugs? Like, you know, if there's 2 different drugs and you're eligible for one, you know, but maybe not another, I don't know. There's a lot of questions about that. Obviously, this is supposed to be you don't have any other options, but I think there's some concerns about how, from manufacturer's point of view, about how this will actually affect their participation and how people maybe will try to avoid participation and get the drug directly because, you know, if you participate in a trial, you know this, you may get a placebo because you may be in the part of the trial that's actually testing against, you know, how the drug works, right? So if you're in a trial and you're going to wind up getting the placebo, it doesn't really help you. So perhaps you want to avoid being in a trial so you know you're going to get the drug. So those are some questions I think that the manufacturers may have. Then there's the medical legal risks. You know, we don't really know anything more than there's a limitation of liability. We don't know, you know, the other things. There's no oversight like compassionate use. There's no like straight line. This is, if we do this, this is going to work. You know, it's a little out there, that kind of thing. Publicity. And then the big one, of course, is the cost of the drugs. If I'm not going to get any of the cost of the drugs back and lots of people are using my drugs through this right to try, am I really like going to suffer a big loss? And I spend all this money trying to create these drugs to make money off of them, obviously. How is the right to try going to hurt that? All right, so there we go, and now it's back to Andrew.
Okay, thank you, Lara Jean. So just segueing from the manufacturers, realize that if the manufacturers do not participate in this process, their perspective is in some ways the only one that matters. Right to Try Act becomes irrelevant. Because unless they give the drugs, we're never getting anywhere. Okay, but the physicians are in an interesting perspective, and we thank we've gotten some input from clients and others who've called us, and as we go through these perspectives, we're going to echo some of those, and I'm sure there's other ones, and people should feel free to send us. We're in listening mode. So as Lara Jean mentions, from the manufacturers, some of the researchers, the clinical investigators are really worried that people will just say, I don't want to deal with this clinical trial. I don't want to have to come every 3 weeks for this and that checkup. I'm not doing it. I want to go straight into the right to try. Whether that becomes reality or not, you know, who can know for sure, but it is a concern that's been voiced by several physicians. Exploitation of patients. Remember where I started, you have 1 million people who are going to die this year from a terminal illness. They are desperate, and desperate people will do some desperate things. And there is a concern that patients may be taken advantage of by a manufacturer who's less than above board, by middlemen, by whoever. But you're a patient, and physicians tell us that you have a terminal illness, and a lot of patients are online. They're finding out about this or that drug, and they're willing to do anything. So that really blends over to the ethical and practical pressures that are on a physician now. A lot of physicians are worried that as this becomes more popular or more well-known, there's going to be pressure on them. Let's say an oncologist has been treating a patient for a couple of years for an illness that's progressed, and they're now going to have to deal with what was described before, the very high standard of whether they have exhausted all approved treatments. But more than that, the ethical part, from what we're telling physicians, is I may have an issue of certifying to give you a drug that I have no evidence will help you. Remember, this is only phase 1. And therefore, I might not want to do it because I have the overriding ethic is to do no harm, and I might do you harm. I may not help you, but and so you start having those philosophical questions. And the problem is, and maybe this wasn't intended by the authors of the Right to Try, but the certifying physician does not need to be your treating physician. So one of the concerns we've heard voiced to us is, so I'm a patient now. I can't get my certifying physician to do this. They're like, listen, I don't know enough about the drug. I just can't say it. I don't feel right about it. So now I'm going to go, I'm the treating physician, and now I'm going to go try to find another physician who may be more of an advocate for this. It's similar to when the marijuana laws were coming out and the assisted suicide. There will be a cohort of physicians that want to push this. And so now what happens to the physician-patient relationship? I've got patients putting pressure on me. If I don't feel comfortable with doing it, there may develop other physicians who will see them. Is that best for the patient? And so you create a lot of internal pressure on the physicians. We are not trying to ruin anyone's lunch. We know there's a number of physicians on this call, but we're just trying to get you to start thinking through those issues. But what a lot of physicians have said to us, and it's not surprising, is, well, what's my liability? So we've talked about the certification. Remember that under the compassionate use avenue, you have to certify as well. But there, it's only the likely risk to a patient for the drug is not greater than the risk of the disease. That gives, some flexibility, much different from the right to try of all available treatments. Where am I going to come up with the informed consent? You can't ask the patient to come up with their own informed consent. Now, from a liability perspective, these are patients, who life expectancy may not be great at all. And so we're not necessarily that worried about malpractice issues. There are licensure issues and things like that. But suddenly I'm a physician and I'm looking at bottles that have been labeled. Now, I used to not have to look at that on clinical trial or compassionate use because the FDA will have signed off on those labeling. But now suddenly I'm looking at it and it's a responsibility I have. That's tough. And then I have to monitor my patients who are taking this drug because I'm their physician, and I might not have enough data to even know about some side effects or whatnot that might come out. And then also, and it's going to be the next slide, how are the hospitals going to deal with this? So I need to understand what my hospital's position is, assuming that I'm giving this drug that will involve an inpatient or outpatient, but it's not just my private practice. So I have to balance that. And then don't forget, we have now armed you with the knowledge of 40 states having their own right to try, which I have to determine. So that's a lot of burden on physicians. Now, if you're not a physician that deals with patients that are in this condition, so you're probably not on this call, but if you are, this is another burden that you have to deal with. Okay. So now we come to the hospitals, who are also in a interesting position. And remember, we've now armed you with all of the information, so some of this should hopefully make sense. If you joined late, I see some people did, I'm going to assume you're going to go back and listen to it on YouTube. But we've already talked to you about the immunity. And we think that that will extend to a hospital. So you have that. Again, as Larry Jean mentioned, we have to see how that's going to develop with the courts. But then remember, most hospitals, I would say almost every hospital, has some policy if they're doing research about how that needs to be functioning inside the hospital. So there'll be a committee, oftentimes or almost always it's the IRB, and the IRB is going to be involved. But is this really research, right to try? We think the strong argument is it's not research. So you're going to have to figure out, if you're a hospital, okay, so first of all, I've got to get all my research policies together and probably add sections to it which talk about right to try. So that's unapproved drugs that aren't in a clinical or compassionate use, did not have any FDA involvement. What do I want to happen there? Do I want the IRB to look at that? Remember that the right to try labeling said it doesn't need to involve the IRB. That doesn't mean you can't. You could set up a different committee. It seems to us, and for the people that we spoke to, the IRB is the right cohort of people to handle that, but we leave that to each hospital's decision making. And then, hospitals are going to be in an interesting position because there's the cost for caring for patients. Let's say a patient has an adverse reaction and needs X, Y, and Z. Or remember, if they're on a clinical trial, a lot of clinical trials have, you have to follow up with MRIs or this or that, and that's oftentimes paid for by the sponsor, or there's a fund or something to take care of that. That may not be here now. And by the way, as we thought about it, those rigors that were complained about in clinical trials and the FDA process of having to check where the patient's health is, that's all up in the wind now. So are you going for that MRI to determine if the disease is progressing or what? I don't know. But who's paying for that? We're going to have more of that when we get to the insurers. But again, a burden on a hospital system that's already burdened. And then how are we going to process these patient requests, and how are we going to deal with that, and who's going to monitor it, the data? We can't just say, well, we're not collecting data because it's not research, but if we find out that in our hospital we've got 3 people taking a drug and they all died within a day of taking the drug, what are we doing? Do we have any ability to even take that data in and analyze it? And then we put down in here that you can still call the FDA, and here's a shameless plug, you can call your attorneys, you can call your risk manager, your office of clinical investigations within your hospital. They can still check with the FDA. What have you heard about this drug? And to the extent they'll talk about it, whether it's confidential, that's something I think the FDA is going to have to really grapple with, and we hope they do. Okay, there's a lot more that we could talk about with hospitals, but we want to see if we can get questions. By the way, you can type questions right in on your screen and they'll pop up. Okay, patients, because this is all about patients. So one of the things that was told to us is a real concern about balancing the expectations of patients. This is, in some ways, my words, not the FDA or the statute. This is a Hail Mary, right? This patient, there's nothing else left for this patient. So what is the patient expecting? Are they expecting recovery? And you have to, I think a physician's really going to have to talk to the patient about that, because you also don't want to be giving them false hope, especially in light of the fact that you may go through all of this and the manufacturer says, you know what, I'm not interested. And the early indications is the manufacturers will not be interested for all the reasons, some of which Larry mentioned, which is, I don't want to get things posted. I don't want to deal with this. I don't want to get involved. So you have to balance that, the fact that you may get them to the 1 yard line and it doesn't happen, okay? But also, they have to realize, and that's the part that seems to be awfully scary, or one of the parts, that you're out there without a safety net. So if I'm a patient, I would say, so am I being, after I take the drug, what system is there for checking how I develop? What should I be looking for if I'm having a side effect? Those procedures for the patients are, as of yet, not there. Now, could a manufacturer say, same way they do for compassionate care, here's what we're going to do. We're going to mimic what we have in the clinical trial. They could not. Hospice considerations. There are hospices could take the position that, listen, you're a patient, you're in hospice, and now you're going ahead and you're going to start taking these drugs. Maybe that means you're not right for hospice. Now, one state has already, I think it was Oregon, has already said that they are not going to make a hospice drop a patient. But I don't know that it's a state issue. It may be a particular hospice versus another hospice. So that's something to consider. And then most importantly, it's the cost of drugs and associated care. And I think doctors always have that discussion with patients who are on clinical trials. It's in every clinical trial informed consent. But here, and that's going to lead to the next perspective. See how this webinar is perfectly constructed. But you may find that the patient didn't get better. In fact, it's likely they will not get better. And they're left, and their family is left with bills that they're going to have to deal with. So there are obviously more patients' perspective. I see somebody just sent a question throwing out more to me. Again, we're at this for less than a month, and we're in listening mode. So we're definitely just touching the tip of the iceberg. Okay, the FDA, not that we care, I don't think there's anyone on here from the FDA, but their perspective informs all the others' perspectives. So the Act very clearly took the FDA out. It undercut their authority and it neutered them. The FDA, is, from what we're seeing, is not looking to fight with Congress and the states, but they're still asserting their role. And so that's going to lead to, the senator can yell all he wants at the FDA commissioner, but the FDA commissioner is going to do his job. And so there's going to be more recommendations and questions. So we think that actually the controversy will help understand this a little bit more. And the FDA has flat out said that, they're working on guidance and they're creating a formal process to handle questions. Because, and here we'll step out and not be as agnostic, there has to be a role for them in this. And their role is that they're a resource. So it looks like they're not shying away from that. And ironically, what may come from this is, I think the FDA has to be hearing the criticisms of the expanded access program and why it's only 1,000 people when there's 1 million people dying. So I think in some ways, while that's still an alternative, we envision that the FDA, or hope that the FDA will begin to improve on the expanded access. So if for some reason the right to try, or for the reasons we've said, the right to try act doesn't really develop, maybe the compassionate care avenue becomes improved. Okay, insurers. We think that this, besides the gaping hole of not requiring manufacturers to give the drug, and we don't think they legally anybody could require a private enterprise to have to give out free things, they also are not requiring the insurers to pay for it. And I know this is a very controversial thing in all research, and I think our firm has been doing a lot of research for many, many years, and we've seen insurers get a little more flexible in what they're willing to pay when somebody's on a clinical trial. However, this is one step beyond, or two steps beyond the clinical trial, because remember, with all payment methodologies, the the insurer has to find medical necessity. So we're almost sure there's going to be a greater pushback on the financial support that insurers are willing to give. And that's going to result in the patient perspective getting worse. It's going to require physicians to have deeper conversations with patients, or physicians have deeper conversations with them, and hospitals to really think about what they're doing. So we haven't heard much from the insurance world, this industry. I think they're waiting to see how this plays out, but I'm pretty sure, and there's none that have registered for this seminar, but I think that it's going to be trouble ahead. And if they don't pay for it, and the manufacturers are not going to pay for it, and there's no funds, then I think the Right to Try Act will have a tough time working for anybody other than people who have means to handle this. Okay, the states. So what do states do now? Now, the preemption that's in the statute is broad. This is not the audience or the venue for going through a detailed preemption analysis. Preemption for the non-lawyers means that if a state says A, but it's in conflict with the federal law that says B, B wins, okay? But when is it in conflict? That's going to have to be developing. If you're lucky enough to live in a state where you don't have a state law, you don't have to worry about it. But for example, the eligible patient that Stacy was talking about, if you look back at that definition, it didn't have the word imminent in there, okay? So you didn't have to be imminently close to death. Most state laws have that. So what does that mean? Does that mean that if I have the broader definition, it doesn't have to be imminent, I can follow that? The answer is probably yes, but it's a probable yes, okay? And if a state who's listening to this, either on YouTube or something like that, and says, yeah, we're going to require a certain amount of revenue to be set aside to cover these drugs, okay, that's great. That's that is not preempted by the federal law, because the federal law doesn't cover it. So that's an instance where, yes, you could be in a state, an insurer has to do it, but the federal government doesn't require, so it's not in conflict. So that's a whole area we could spend a lot more time on, but we do not have time. Okay, so before, and now if you're following along, we're on 27, which is the next step. Before we do that, I want to just say where we've come. We set up what was in existence, clinical trial and compassionate use. We talked about how the states jumped out ahead, how there's a big controversy. We talked about you have to be the right patient with the right drug in the right circumstance with the right doctor who's willing to certify it with the right amount of costs or the permitted costs, and you have to then get a manufacturer who's willing to do it. So, okay. So I see somebody wrote a question, is this ever going to work? I'll answer that one. I have no idea, okay? But you can't sit around and say to yourself, well, I'm not going to deal with this. I'm going to just wait. You don't have that leisure. So whether you're an individual or you're a hospital, you've got to kind of come up with some policies and processes of how to deal with this. So for example, I had an oncologist say to me, well, what do I do? I can't spend all day dealing with this. And, you have to figure out which patients are you going to, or you're just going to say, I'm not interested, right? Hospitals don't have that leisure. There are going to be patients and physicians that are going to be clamoring for this. So you've got to look at your policies, harvest the policies, and make whatever changes that you think you want to make. But first of all, you have to have a group that's willing to consider this. I don't think this is an interdisciplinary approach. If I ever saw one, you're going to need a lawyer, you're going to need a clinician, a researcher, you're going to need that group, okay? And then you're going to evaluate it, and you're going to decide, okay, so if we're going to open up the window this much to this, how are we going to monitor it? A lot of hospitals have ethical committees. How are they going to, because I think a lot of this is going to go to them. You're going to have controversies where a family's saying yes, doctors saying no, and how do you deal with that? But most importantly, and this today really is the first step towards that, most importantly, you have to educate the medical staff and the nursing staff about the right to try. We're still hearing doctors say to us, what is that, right? And that might be okay. If you're a doctor that's not, in an area of medicine where you're going to have those patients, you can stay ignorant. But if you're on this call, it probably means that you're interested in this area because it's important to you. So you have to educate the medical staff and then the nursing staff. Now, you can't educate them, at least I'm talking to the hospitals now, can't educate them until you know what you're educating them about. If you want to just talk about the right to try, that's fine, but I wouldn't want to get up in front of my medical staff and start talking about this without saying, and here's what we're going to suggest that we're going to do about it. But remember, there was no comment period, so you're already a month behind the deadline. And then we're going to have to monitor what's going on here. And the changes that are going to go on, we will try to set up a database and send it to everyone who is on the call. If there are people in your institution, and I know we've gotten some calls, people couldn't make it. If there are people who we want to add to the list, just send us an email. Our contact information is at the back. Okay, now, the most important thing is the questions. So I'm going to put the first question to Lara Jean. Lara Jean, the question is, can I just refuse to participate? We don't know who wrote that question, but let's assume it from all the different perspectives.
All right, so the answer to that question is, in a vacuum, yes, because the law doesn't require anybody to actually do this, right? It doesn't say a physician, you must, agree with the patient and you must be willing to do this. It says, it gives you the criteria for agreeing. But then the question is okay, yes, so okay, in a vacuum I can say, yeah, I don't have to participate. But what happens when my patient comes to me and has this request, right? That's a much more difficult perspective. And then, of course, it's a difficult perspective from a hospital as to, you can't just tell all your physicians, just don't participate, or you could try, but, you can't control all your physicians and someone's going to want to do it, and then where do you go from there? So although, the answer to the question in a vacuum would be yes, I don't think that that's the approach anybody can really take, and you have to deal with how you want to address it if somebody comes forward.
Okay, also somebody asked, it's a question about answering questions. Will you mention our names if we ask a question? No, we will not. So the next question is, if the drug works in a lab, would not a manufacturer, free of liability, want to gain the FDA approval process by encouraging a right to try process to get the drug to market quicker? So it's a good question. And I'm not sure. From what we're hearing from some manufacturers, they're being a little reticent. It's a gamble. And I'll just be a manufacturer for a second, even though I'm not. Yeah, I see the question and I get the point. But what happens on the opposite side, right? I spent millions of dollars developing this drug. I've got all these investigators who are going to watch, monitor, a whole reporting process about adverse events. I can determine if they're related to the drug, not related, all the things that the researchers on the phone spend all day with. Now I'm just going to give the drug to this person without really any monitoring or systems behind there. Because if that patient gets really sick, first of all, it might have nothing to do with my drug, but I'm going to have to report that to the FDA. And the FDA may say, well, you know what? I remember, they'll think back to what, well, they won't think back, but think back to what Lara Jean was saying. They have the break the glass provision. Well, if we think, here are criteria that why we can take it into account, we can take it into account. I don't know if I spent millions of dollars developing something, I want to take that gamble. So it could be, but I'm doubtful.
And also consider that the FDA is not going to be required to consider your clinical outcomes, right? You can ask them to, but there's nothing that says they have to. So if you go this approach and then the FDA just says, I'm not going to consider your clinical outcomes, you've really gotten nowhere.
Right. Yes. Okay. And by the way, the problem with the internet too is, you can't control what a patient's going to do. So a patient could say, they gave this to my friend and he ended up dying 10 minutes after they gave it to him, and now it's in the blogosphere and all that happens. So yes, that could happen in a clinical trial, but when I have thousands of people doing it, I don't know. So let's wait to see. Maybe we'll have an anniversary party in a year and determine. Okay, next one. This must be from a physician. How much research is required to determine that all treatments have been exhausted? So I can take that one. The answer is I don't know. The questioner is asking a good question. It actually doesn't say, it says exhausted treatment. It doesn't say the word all. I think the word all is implied, but I don't know that it's clearly there. But yeah, I don't know how much research is required. I think, look, if you're an oncologist and you do a database search and nothing comes up, that's probably enough, okay? I think the more difficult question is you do that search and there's some little country that has a little clinical trial looking into it, this treatment that no one's really heard of. I don't know. Does that mean I can't certify now because I didn't exhaust treatment options? I think one of the clarifications will be all reasonable treatment options, all treatment options in the United States, all treatment options that the physician believes in his discretion is appropriate. None of those things I just said are in the statute, and FDA, if you're listening to this on a YouTube, please consider that. Okay, so I think unfortunately we're out of time. Everyone stayed in there, so I really, really appreciate it. I see there's more questions. One just popped up. Please call or we will respond to the ones we have. We thank you very, very much. And thank you very much to my colleagues, Lara Jean and Stacy, who worked really hard in putting together a great presentation. Thank you.